Namaste and very good afternoon, friends. Today, we will be discussing regarding a type of clinical trial, but it is not randomized controlled trial as we always take it to be, but it is the pragmatic trial that we will be discussing about. And while we will be discussing about the pragmatic trial, we will also be discussing about the PRECIS-2 tool. In fact, the presentation is more inclined towards the PRECIS-2 tool, which is being used in the case of pragmatic trials. The whole presentation is divided into two parts. The first part is regarding the introduction to the pragmatic trials. In this, we will see first what's a clinical trial. We'll just make a reference to it, and then we will see what is a pragmatic trial, and then we will see how it differs from the randomized controlled trial. So, if we say clinical trials, obviously we all know it is something which is being done first to provide the research data, or we call it as the evidence about the interventions that we test. What comes out of the clinical trial is definitely an information, a scientific information, for that matter, a scientific evidence that comes out. And what else comes out? What therapies or other interventions might work best? Which is the intervention that is working best? Which is the treatment which is working best? And that's why we either compare the two treatments, or we compare a treatment with the control group which is there. Maybe sometimes it is placebo also. That is why we do the clinical trials. And for what we do clinical trials? For what? The first and foremost, that is drugs, as we call them, medicines nowadays. Drugs, when we call, maybe sometimes it is referring to the substance of abuse. So we tend to call it nowadays medicines, or we test any of the devices which are there, maybe some surgical approaches which we want to test, as there is a lot of progress in the cataract surgeries. Previously the people had to take rest for 15 to 10 20 days after the cataract surgery, but nowadays the things are different. So there are no new surgical approaches, those are also to be tested. So devices are there, surgical approaches are there, maybe radiation therapy, maybe some of the diagnostic procedures like some new MRI techniques, maybe some of the new screening technique which is there, and finally regarding the diet and the lifestyle. So the clinical trials, they deal with drugs, devices, surgery, radiation therapy, diagnostic procedures, and what the diet or the lifestyles. So at present, if we see, most regulators across the world use the results from randomized clinical trials, right? Randomized clinical trials which are there for approving the drugs. We all know that. RCT provides the proof for efficacy. The keyword here is efficacy of the drug in the controlled environment. Yes, it tells us about the efficacy. But how? In the controlled environment. We will have the required number of people. We will keep them in the controlled environment. Strictly, we will see that they adhere to the therapy which is there. Then we will conclude something from that. But the results are usually not enough. The keyword here is not enough to prove the effectiveness of drugs in real world situation. Another keyword that comes here is the real world situations. So in the real world situations, it may or may not work. That is what is the real world evidence, as we suggest. Because in the real world, the things will not happen in a controlled manner. The people will take the drug as per their understanding of that particular drug. Maybe the people are on different paths simultaneously. Maybe the people are consuming different types of food with different frequency which is there. Also the age group also varies a lot which will take the drugs. So many a times we see that the efficacy as well as the adverse drug reactions, we come to know that the drug is not that good as it is being shown in the case of the controlled trial. So this is the real world situation. There is a paucity of evidence in the clinical trials whether it will work or not. Now, randomized control trial, we will see what are its strength and what are the limitations. One of the strength is the high internal validity. What do you mean by high internal validity? High internal validity is something is the accuracy of measurement. There is definitely an accuracy of the measurement. We have stringent SOPs, that is standard operating procedures, that are being followed. Definitely it is there, but there is the limitation is limited external validity. External validity means how much it is able to project or how much it will be true for the common population which is there. So that is what is called as the external validity. Though we have statistical tests and other things, those will tell us about the external validity, but the variations which are there in the real world, those are not taken into considerations. So limited external validity. Obviously there is a high cost which is there, which is one of the limitations which is there. Investigator has control over the patient exposure. Limitations are some ethical considerations. Prospective data collection and limitations is generally shorter duration. Up to few weeks the trials go. The trials will not go for a long duration of time. By and large, that is what. And then inefficacy of detection, that's why rare and delayed outcomes which are there in the real world situation, that is how randomized trials will go. That's why what we want is some approach which will give us the idea of how the drug will be acting in the real world situation. And that approach we call it as the pragmatic approach or pragmatic trial. If we want to see, say, pragmatic trial, pragmatic approach, then one should understand what is the meaning of this word pragmatic. The meaning of this word pragmatic is something related to the matters of practical affairs. So practicality is something which is a pragmatic approach which is there. Now what do you mean by the practicality, the practical approach which is there? Let me give an example. Practical approach. We know regarding the COVID-19, in COVID-19 pandemic when it was there, we wanted that people should stay at home, they should not go here and there and spread this disease. So what is the idealistic approach? Is educate the patients, educate the community, ask them to be at home, and with this education we will envisage that a day will come when the community will understand that and they will stay at home. But this is not a pragmatic. The pragmatic approach was lockdown. So this is how the practical approach, that is the pragmatic approach. And as we see the use of this word pragmatic in 1800s, we will see the very few use, very uh, uh, not very extensive use of this particular word pragmatic. As we are going to practicality, especially from 1900 onwards, you can see that how frequently now this word pragmatic even is being used in the literature also. So that is what is pragmatic trial. Who developed this pragmatic trial and when? It was in 1967, two scientists, Schwartz and Leloch, who developed this terminology of the pragmatic trial, and they called it as real world evidence which is there, or real world data which is there. If you want to define a pragmatic trial, how the definition goes, let us try to understand it. PCT stands for Pragmatic Clinical Trial, defined as a trial designed for primary purpose for information decision makers regarding the comparative balance of benefits, burdens and risks of the biomedical or behavior health interventions at the individual or population level, as Cliff et al. Puts there. The significant elements of PCT are, there are three significant elements. First is, it is not only for patient, clinicians, regulators, administrators, because these are real world people who are associated with that particular molecule. But most important are these two. The first, that is second, is enroll representative patient population for whom the decision is relevant. Representative. We will come to know what exactly this representative population means. And measure a broad range of outcomes, isn't it? Broad range of that impact clinical practice decision by providing comparative benefits of intervention. Broad range of the outcomes. It is not narrow range of outcomes, but the broad range of outcomes, that is very important. So these two things are very important when we come to what is the pragmatic clinical trial is. Let us move ahead. Let us try to analyze both, that is explanatory, it is RCT, randomized clinical trial, and this is PCT, that is pragmatic clinical trial. Head to head, let us try to compare it. So RCT, otherwise we call it as explanatory. Explanatory, it is very much similar to the RCT. Homogeneous patients are there. We have the stringent control over how the patients who will be including in the research, like the inclusion criterias, like the exclusion criterias. So homogeneity of the patient is there. Secondly, there is tightly defined interventions which are there. Two things. Tightly defined interventions. What are the interventions which are there? Tightly defined SOPs and all these things. But in pragmatic, there are real life patients. There cannot be stringent criteria of inclusion and exclusion. Flexible interventions with the changes. As we will move ahead with the presentation, we will come to know. Explanatory trial or RCT, clearly defined control group. We do not have active comparer instead of the placebo. We cannot have placebo here. Explanatory objectives and surrogate outcomes are there. But now perhaps most important, in pragmatic test, it is clinically important what outcomes. Let me take an example. Let me give an example. Suppose there is a drug which is antihypertensive. What we take into consideration in explanatory RCT, that the blood pressure, raised blood pressure should come down to the normal. But is the patient coming to the doctor for the purpose of increased blood pressure? No. He has clinical manifestations which are there in the form of throbbing headache, maybe in the form of difficulty to walk, maybe in the form of the weakness that is continuously developing, maybe in the form of sleeplessness. Patient comes for that. So we are more on the surrogate outcomes which are there, but here clinically important outcomes. Yes, BP is normal, but whether all these manifestations have come down. So that is what is the pragmatic. They are short terms, sometimes, for example, 6 weeks or so, but these are long terms, more than 6 months or so, which will give us, because the person will not like to take the medicine as far as the chronic diseases are concerned. Pragmatic approach is at least following the patient for 1 year or 2 years, because that is how the treatment goes. It is not the matter of 2 months, 3 months, or 4 months. So there is a widespread concern that explanatory randomized trial can be poor predictors of the real world. And number of times we have seen this particular thing happening, that is in randomized control trials, randomized clinical trials. There are very few of the adverse reactions which come to light. Efficacy also is again doubted whenever it comes to the real world situation when the drug is introduced into the market. The remedy, we are quite sure about that. The remedy is something which is called as the pragmatic trials. Is there any instrument to tell us? Now, if we, what is pragmatic? Let us concentrate on this particular word once again. Pragmatic is the word which mostly is an adjective. Pragmatic trial. How, which kind of trial? Pragmatic trial. So pragmatic is a kind of trial where we have two types of the things which are there. That is, one is how much pragmatic the trial is, or how much the informative that particular, or RCT type that particular trial is. So pragmatic is something, it is what? It is the adjective which is there. So is there any tool to tell us that how much pragmatism is there in my trial? Trial might be RCT, but how much pragmatic, how much practical, how much real life this particular trial is there any tool for that? Yes, there is a tool called as PRECIS-2 tool, and that takes us to the next part of our presentation. Part 2, we have the specific objectives related to that PRECIS. We will see what is PRECIS-2. We will see why the PRECIS-2 tool is designed. When was PRECIS-2 designed? And who designed the PRECIS-2 tool and how to use it? So now the second part is totally around this particular PRECIS-2 tool. PRECIS, it stands for what? This PR stands for, no? PR stands for pragmatic. This E stands for explanatory. This C stands for continuum and indication. I stands for indication and S stands for summary. So what is PRECIS? Pragmatic, explanatory, continuum, indicator, summary. That is, this tool tells us that whatever protocol we have, how much pragmatism is there in that particular protocol. Let us see. If this is PRECIS-2, then rationally one might think that where is PRECIS-1 and where that particular PRECIS-1 has gone. So let us see a bit of history which is there. Originally, PRECIS was developed in 2005-8 by 25 international trialists. It is not the contribution by one person, contribution by 25 trialists who came together, experts. And PRECIS-2 later on was developed when 80 international trialists they came together. So it is a collective effort altogether of the scientific community to develop this particular tool which is there. So let us see a kind of history here. Gert Lehner and et al. Proposed the set of 7 domains, 7 characteristics on which it can be analyzed how much pragmatic a trial is. But later on they found that these are not sufficient enough. So Throp et al. In 2009 introduced the term that is PRECIS. And how many of such characteristics were there? So there were some 10 domains, as you can see here, there were 10 domains of it under which this PRECIS tool was being used. But later on, it was further developed to perfection and called it as PRECIS-2 in 2015 because PRECIS-1 is in 2009. Though they did not call it 1, but when they again reframed it, they called it as 2. It was validated, and now how many domains are there? There are 9 domains. What are the domains and all? As we will go ahead, you will be more clear about, we all will be more clear about these 9 domains. So PRECIS-2 helped the trialists work through their design decisions so that they might avoid designing a trial that did not match their own intentions. So what is the use of such kind of trial? When the control environment is there, you are putting the people of a certain age group in a controlled environment. You are controlling their food, you are controlling their diet, you are controlling their compliance, and you are controlling all the environment around them, and coming to the conclusion that the therapy is effective. While when the therapy comes into the market, when goes largely into the real world, nothing of that sort happens. So that is very important here, that is own intentions for clinic. Now let us see what are these 9 domains one by one. First is eligibility criteria. The second one, recruitment. Third one is setting. Fourth, organization which is there. Fourth, flexibility in delivery. Flexibility in adherence. Seventh is follow-up. Eighth is primary outcome. And ninth is primary analysis. On these criteria, let us weigh our trial and how much pragmatic it is. But how it is to be done? How the scoring is to be done, and how we will come to know about this. So let us see this particular thing. It is scored for 1 very explanatory to 5 very pragmatic, for each having 5 scores, 1, 2, 3, 4, 5. Maybe on eligibility criteria it is very much pragmatic, that is 5. 1, 2, 3, 4, 5. And recruitment criteria, it is not very much pragmatic. So we have the score from 1 to 5, where 5 is idealistic pragmatic, while 1 is not that pragmatic, right? So that is there. So this is how a wheel, now how to use it. It's like a wheel which is there. Can you see? 1, 2, 3, 4, 5. Here also it is like 1, 2, 3, 4, and then 5 at the periphery. Here also 1, 2, 3, 4, and 5 at the periphery. What we have? Eligibility, who is selected to participate, recruitment, how the participants are recruited, setting, where is the trial is done, organization, flexibility, then adherence, follow-up, and primary outcome. And we have to have the score here somewhere, and we have to mark that particular score. Let us take an example and let us try to see with the help of an example. What is the example? A trial consisting of evaluation of drug X in the treatment of hypertension. Let us see how we will be utilizing. Very simple. We have a drug X which intend to decrease the blood pressure to the normal, the increased blood pressure. Treatment of hypertension. Now let us see one by one. The first is eligibility. To what extent are the participants in the trial similar to those who would receive this intervention? Now see, we are recruiting the age group of 30 to 40 years, that too male. But what we intend that this drug when goes to the market, people from various age groups will take it, including the women. So that is there. So it's not that pragmatic, the eligibility. Recruitment. How much extra effort is made to recruit the participants? Here we are saying that we will recruit 60 participants per day. But in a medical college or with the practitioner or where from the recruitment is done, only 20 new cases appear each day. So where from the next 40 cases will come? We should have a recruitment drive for that particular thing, which is not pragmatic at all. What is pragmatic? At least 20 new cases or less than 20 new cases per day can be included. Setting. How different are the settings of trial from the care setting? Conducting the trial in tertiary care setting. Now we are conducting the trial in tertiary care setting where everything is controlled, all the types of investigations are available, and where the drug will be utilized once it is in the market, primary health care. So is it okay to conduct the trial in the tertiary care? No, this is not pragmatism at all. Organization. How different are the resources, provide expertise and organization of care delivery? In the intervention arm, we are recruiting the healthcare specialist, normally not available now, healthcare specialist. Now see, where we are utilizing this drug, where we are conducting the trial, specialists are available. MD specialists, DM cardiology specialists are available for caring the patients. While in the peripheral healthcare center, there are only graduates, maybe some MBBS, maybe some other pathy person is there treating the patient and not the expert. So organization. Flexibility. How different is flexibility and how intervention is delivered and flexibility anticipated? Drug X is delivered in very controlled setup with diet restrictions, which otherwise will not be there. So is it pragmatic? No, diet restriction not pragmatic. Flexibility towards adherence. How different is the flexibility and how participants are monitored and encouraged to adhere to the intervention, adhere to the therapy monitoring by therapeutic drug monitoring technique. Otherwise, is therapeutic drug monitoring technique available at the periphery or even at the private practitioner side? No, it is not. So we should have some other methodologies to ascertain the flexibility adherence towards the therapy. Follow-up. How efficient is the intensity of measurement? We are calling the participants for twice a week follow-up. But does it happen in the clinic? No. The follow-up is once in 15 days, maybe once in 10 days, maybe twice in a month or something like that. So our follow-up is also not going as per the real world. That is not pragmatic. Primary outcome. To what extent is trial's primary outcome directly relevant? Study looks at mortality rate over a short duration of time. It may be 3 weeks, 6 weeks, 10 weeks, month or two. No, because drug is for a chronic condition. So we should have this over the duration of at least 1 to 2 years. That is more pragmatic. Analysis. To what extent are all data included in the analysis? We are including all the data. pulse, BP, periodic ECG monitoring, even for that case, some coronary angiography, this, that. But all this data, no, it is not being included whenever the drug will go into the real world. It is probably the clinical outcomes which are more important in the real world as far as efficacy is concerned. Now, what we will be doing is, we will be now marking it. How much is this particular thing is pragmatic? Maybe 2, maybe 1, maybe here 3, maybe here 5 or something like that. And then we will connect these particular dots to get a diagram something like this. In this diagram, what is being shown is a good pragmatic trial. You can see the whole thing that is being covered. You can see here 5, 5, 4, maybe 4, 4, 4, 5, 5. So all these things, this is how a pragmatic trial looks like. So you have a trial, how much pragmatism? A good number, good amount of pragmatism. But how non-pragmatic trial will look, can you see here? What's make the difference, right? This is something which is very much skewed on one side. This is 1, maybe 0, maybe 1 or 2 or 3 or 4. Nothing comes on the 5. So this is not pragmatic at all. This is explanatory study, your RCT. And this is the pragmatic study which is there. Your RCT can also be pragmatic, but if the RCT is not pragmatic, RCT is mandatory, what we should do? We should back our study RCT with some pragmatic trial also, because that will back our new intervention more strongly. If I say it is good at RCT point also, and when we conducted pragmatic study, it also proved better. So that is there. Now let us see one by one. I will not be going through the whole thing which is there. But what is the most extreme pragmatic approach? So eligibility criteria, who is selected to participate. Inclusion, we can include elderly people, people with range of comorbidities or something like that, even children, because if it is intended for children, even that particular thing can be utilized. People with a probable diagnosis, now very important, probable diagnosis rather than laboratory confirmed. Many a times we do not confirm the diagnosis laboratorily, we confirm the diagnosis just by clinical manifestations. So we can include in such manner. Narrow eligibility criteria, if a particular narrow criteria are similar to those routinely used. And what is the exclusion? Maybe age over 80 years we can exclude, but this is very much pragmatic. Rather than non-pragmatic approach, I will take only males in the age group of 30 to 40, that too who are non-diabetic under this particular study. But this doesn't happen in the real world scenario. Eligibility criteria, can you see PRECIS score is 5, very pragmatic. All the patient ages over 15 years can be included if a drug is intended for them. We cannot have restricted age group which is there. Recruitment, how the recruitment, most extreme pragmatic. Only people who attended the clinic, we will not have advertisements like please come and join our trial. No, whosoever are attending the clinic and agree for this particular trial should be included. That is what is the pragmatic approach altogether. You can recruit even from more than one clinic, you can recruit the patient. The setting, now you can see here PRECIS score 2 here, and this is the PRECIS score 5. Single centered, right, approach, who is specialized, and we are recruiting the patient only from that single center. PRECIS score is 2. It is rather explanatory RCT type. But here, example 2, ibuprofen, paracetamol and steam for patients with respiratory tract infection in primary care. So the setting is what? Primary care. So I will include the patients from primary health care setups. So that is what is PRECIS score will be 5. That is more pragmatic. Organization, we have said organization. Can you see here PRECIS score 5? Early lens extraction and intraocular lens implantation to treat glaucoma. We should have expertise, yes, in this particular thing, ophthalmologist. But we will not give any additional training or additional resources for that particular purpose, because that is not provided to each and every ophthalmologist who will be giving this drug or something. So that is how the things are. So the pragmatic score is 5. Flexibility, see the flexibility. Flexibility adherence, example, music therapy to support communication in autistic children. The sessions were all individual based in the interaction with child and allowed for the range of response. Otherwise, in RCT, how we will say that in a week, 2 sessions should be conducted or 3 sessions should be conducted. Here, it is not that restriction. It depends on the therapist. You may conduct 2 sessions a week, maybe three, maybe 1 session in 10 days, 1 session in 15 days. That is allowed, that is flexibility, and that is what makes the score very, very pragmatic, which is there. Follow up, can you see PRECIS score only 1 here? Because follow up, they have stringent follow up only on the 1, 3, 7 days, maybe 14 days or something like that. So that is how it PRECIS score has 1. But now here, can you see self management course of chronic musculoskeletal pain? So follow up for the primary outcome requires self completion of the postal validated questionnaire, which is there. They will be sending it to the post. Collection for secondary outcome use 6 additional poster questionnaires which are sent at 6 and 12 months, which are there. Here also they are mentioning the month which are there, and postally they are conducting this particular follow-up. That's why you can see here that the score remains as 4. It is not as pragmatic as there, because nobody will have that postal communication and all with the patients. Otherwise, real communication with the patient, wherever the patient comes for the follow-up, as per the desire of the doctor, that will be more pragmatic here. Primary outcome, early treatment with prednisolone or acyclovir in Bell's palsy. Now see how the outcome is there. Outcome is rated on the base of this particular score, House-Brackman scale. And then test not routine, but this test is not routinely used whenever the things are being cared. So the primary outcomes here, it is based on the scale, which otherwise nobody is utilizing, or very few people are utilizing, very few clinicians are utilizing, and that's why the score 1, it is very much explained. It is not wrong, but it is very much explanatory, very much controlled. It is not going closer to the real life situation. So this is how we have seen. This is how the PRECIS tool will help us, and it is something which is very, very simple to jot down, or very simple to draw this particular diagram in a circle. But is there any shortcoming? There is, because there is, absolutely correct. There is a subjectivity here. Who will decide that whether on the scale of 1 to 5, the recruitment should be given 1, 2, 3, 4 or 5 scores? It is a collective wisdom of the experts coming together. That's why I say that there is a subjectivity. But that subjectivity will not be vastly varying, but yes, it will vary. That subjectivity is still there in this particular tool. So this is the shortcoming. So in a nutshell, what we can say is it's a good approach, the pragmatic trial. But in the case, if RCT is that is what required for the clinical trials, which are mandatory, one should go with that. But one should have a backup with this particular pragmatic trial for the same intervention or the drugs or the surgery or whatever things we are trying to analyze, to prove it further that our intervention not only works in the controlled atmosphere, but it also works in the real world situation. So second, have we fulfilled objectives? What is PRECIS-2 we have seen. Why designed we have seen, because real world evidence. When was PRECIS-2 designed? We have seen that PRECIS-1, PRECIS-2. Who designed? Group of experts who are there. And how to use? We have taken the example, we have drawn the diagrams and other things we have shown, and this is how we have come. So here is an inspirational word. Why all these things we are doing? Why we want to test ourselves again and again? We have already tested for randomized control trials. Why want to test again in pragmatic clinic? Because for all this exercise, the beneficiary is the grassroots patient, because we want that patient should be benefited. And it is very aptly and beautifully has been mentioned in this verse from Mahabharata Drona Parva by King Ratideva, who was being given the boon of asking anything. What he asked is, we should pay attention to that. Natvam kamay rajyam na swargam na punarbhavam kamaye dukkha taptanam praninam artinashanam. It says, I do not want any kingdom, nor heaven, nor for even the escape from rebirth, I do desire to pray for the alleviation of the sufferings of all the living beings. As a researcher, we also fall under this particular thing, all living beings. So, the more rational we are scientifically, the more we go closer towards alleviation of the sufferings of the human beings. And that's why this particular, so I acknowledge the PRECIS-2 field design, the team that is Christy Lorden, Sean, Frank, Peter, Kelvin, and Merrick, who had this PRECIS-2 tool designing trials, and they have put their findings very effectively on the net for utilization. Dr. Nipa Mendapara, who has put another of her researches on the net. We have based our presentation largely based on these researchers who have put it on the Google for the use of the scientific community. So thank you very much for your patient listening. Thank you all.